Thank you all for joining. As a public service announcement, in case you're as disoriented as I am, today is Monday, April 13th. My name is Shen Lei. I am the CEO of AmCham Singapore and also an adjunct associate professor at the NUS Swee Hock School of Public Health. Co-organizing this webinar with AmCham and the School of Public Health is the SingHealth Duke-NUS Global Health Institute. Today's webinar is the first in a series of 4, which will be held this month, April. And as you can see, webinar number 1 will give us an overview of a COVID-19 world. What do we know? How are governments responding? Thank you for the many questions you've submitted thus far. Please feel free to use the Q&A interface as well. As you can imagine, we won't be able to get to all of the questions, but hopefully we will be able to address some of them. Now I'd like to introduce Dean Teo Yik Ying of the NUS Swee Hock School of Public Health, who will be our moderator today. Dean?
Thank you very much, Xian. So it's a pleasure to be moderating the first seminar for everyone. And I think we live in very interesting times right now. And this is the first time that we are going to run a webinar where the sign up for the participants have exceeded 1,000. So thank you very much for joining us. I think most of you are not here to listen to me talk, but rather to our distinguished panelists, and this is where I will turn to them. We have 3 panelists today, and really very relevant to the topics that we want to talk about today. We have Dr. Shawn Vasoo, who is the Clinical Director for the National Center for Infectious Diseases in Singapore. We have Dr. Kiesha Prem, who is a research fellow in 2 institutions at the London School of Hygiene and Tropical Medicine, as well as the School of Public Health in Singapore. So Kiesha has been very much involved in the modeling responses, not just locally in the UK, as well as international. And then finally, we have Ms. Caitlin Asjes, who is the Senior Director of Government and Public Affairs Division at the Becton Dickinson company. Many of us will know that it is a medtech company, but actually it is also involved in health responses, both regionally and internationally, focusing on economic and social impact. So without further ado, I would like to start off by inviting Shawn to kick off the webinar and spend perhaps 5 minutes to talk about clinical aspects of COVID-19 to get us started on learning a little bit more about why the coronavirus has this devastating impact on life and livelihoods around the world. While our panelists are speaking, I strongly encourage the audience. Many of you have joined, thank you very much. You can submit your questions while the presenters are speaking through the Q&A tab at the bottom of the Zoom platform. So with that, Shawn, can you take us through your talking points? Over to you, Shawn.
Yeah, so this pandemic, which the WHO declared, it started off as an epidemic, is again one of a series of 2 other coronaviruses which have caused epidemics in the past. And the other 2 I think we are very familiar with, which is SARS in 2003, with which the current SARS-CoV-2 shares great similarity to, and is most closely related to amongst the 3 zoonotic coronaviruses. So when we say zoonotic, means it comes from animals. And then MERS, as you know, which emerged sometime after that, and then COVID-19, which is the disease that it causes. Now, what is different from a clinical aspect from SARS and MERS is that COVID is a community-based pathogen. It can cause hospital outbreaks, but what is strikingly different is that it has a wider spectrum of disease manifestations, from very mild to even asymptomatic disease that we see in younger people and children, and even adults. And you also get a similar, what we call a phenotype or a clinical feature, where COVID-19 also, reminiscent of SARS, can cause very severe disease in certain populations, and sometimes even in people who we do not expect the typical severe risk factors, and very much like a SARS-like disease. So I think this is probably the main thing which has driven a lot of the spread around the world, and really community-based outbreaks, and really marks it apart. Although it is a coronavirus, it's very different from MERS, which generally has been centered around the Middle East still, and closely associated with its reservoir, with the camel, and SARS, which was different, where illness patterns were very distinct, and transmission was thought at that time to be predominantly when people were symptomatic. Now we have disease which is mild and indistinguishable clinically from the common cold, which perpetuates this transmission. And the other thing, I think clinically and from an operational standpoint, which has marked this outbreak apart from the previous coronavirus epidemics, is the rapidity of spread across many countries. And despite the mortality rates, which are quoted to be lower than SARS in 2003, the absolute number of people is affected, and the absolute number of deaths, and the ability to overwhelm medical systems has been clearly seen through the experience which has played out in different parts of the world. So this was what strikes me now. I guess if you'd like me to talk a bit about what we do clinically, in terms of manifestation, people can present with common cold-like symptoms. In our clinical experience, the National Center of Infectious Disease has seen most of the nation's cases. We have seen over 900, close to 1,000 cases at our center. About 50% of patients have pneumonia on presentation, so about half. The rest actually have a mild form of the disease, which is quite indistinguishable from the common cold. Of those who have pneumonia, overall, then about 20%, or maybe another half or slightly less than half, have a more severe form of pneumonia. And then we have about 5% who are critically ill and need ICU care. Those are the patients which we are really watching out for. And those people who tend to get into that category of more severe illness are people who are a bit older. So generally we say about 50 years or older, or who have comorbid conditions, for example, cardiovascular disease or diabetes. In terms of treatment now, there's a worldwide rush to look for what is the best therapeutic for this agent. Right now, multiple trials are going on. We have a few promising antivirals which are being trialed. Some of them are repurposed, some of them are new, relatively new. And we do not have very robust data right now as to what is the best antiviral that we can use. Obviously, if we have an effective antiviral that can, we can predict who might go towards more severe disease, and we start those antivirals earlier, then possibly we can prevent people from getting to ICU and getting sicker. And so these are challenges. I think on the clinical front, we have, besides the predictors I've mentioned, and multiple other countries have come up with predictors. We know that people who have comorbidities, who have a lower lymphocyte count, which is a white cell, which is depressed during acute infection, and who have raised certain types of inflammatory markers which are raised. In the hospitals, we do something called CRP, or C-reactive protein, and that is an inflammatory marker, and something else called lactate dehydrogenase. That's a marker of tissue damage. And if those are raised, then we do particularly watch out for these patients, for they tend to go south or turn worse with disease. And of course, I think there's an ongoing race, and ongoing people are looking into vaccines, and that will unfortunately take a bit of time as it gets into human trials. And the earliest people predict would be about a year and a half before anything can be put in the market, which is durable and possibly effective. But I think it's going to be a bit of a challenge, yeah. So meanwhile, curbing spread by the measures, the public health measures that are being taken right now by governments all over the world, that remains very important. Yeah, over.
Thank you very much, Shawn. For those that have just joined us, that was Dr. Shawn Vasoo, the Clinical Director for National Center for Infectious Diseases here in Singapore. Shawn, thank you so much for taking time out of your very busy schedule. You're very much in the front line, and I know that this is a time that you are supposed to be resting, but you have very kindly devoted some time to share with us and to help to educate our audience as well. So thank you very much. We will not take questions at the moment. We will leave that all the way after all our three presenters, our three panelists have presented, but we have been taking questions. You can continue to add on your question using the tab at the bottom of the screen under Q&A. And then Shawn, already there's a very relevant question for you to take on later on. I will direct that to you, which is really around why hasn't been any advice really given on trying to strengthen immune systems with vitamins such as vitamin C, D, and zinc. I will come back to you, Shawn, with that question. But Kiesha, now over to you. And Kiesha, it's the research fellow, very much working in the modeling space. She will be telling us about what mathematical models is trying to inform us during this particular pandemic, not just informing us locally, but also trying to tell us what is happening in other parts of the world. Kiesha, over to you, please.
Good afternoon, everyone. Thank you for joining us for this webinar where we try to make sense of what we know about the current COVID-19 pandemic, and we understand how health officials and governing bodies are responding. So Dr. Shawn Vasoo provided a clear discussion of the clinical front of the current COVID-19 pandemic. In today's session, I will cover three aspects of the issue. First, what can mathematical models tell us? Second, do we have a sense of how this pandemic is progressing or likely to progress? And I'll wrap up by discussing if the epicenters will continue to shift. So many governments across the world are relying on mathematical projections to help guide decisions in this pandemic. These models can be useful tools for those of us who are interested to know how and where the pandemic is heading. Still, before we attempt to interpret any models, we should first ask, what are the aims of the models and what are the mechanisms behind it? In general, all models simplify reality to do so, and they do so in order to draw our focus to some sections of that reality. Many transmission models that simulate how COVID-19 spreads are similar in a sense that they are formulated around how individuals in the population move from one state to another and how quickly they move. Susceptible individuals may acquire the infection and become infected and eventually die or recover. So the most basic models assume that everyone have the same chance of acquiring the infection from an infected person. They also assume that the population evenly interacts with one another and that individuals with the disease are equally infectious until they die or recover. More advanced models account for age, sex, the health status, and the social behaviors like mixing patterns, who meets whom, when, and in which places. So one of the challenges we face in the middle of the outbreak is that we don't typically observe the transmission events themselves. Instead, we just observe people becoming ill and needing hospitalization. The cases and the deaths that we see today probably started as infections weeks ago. So when modeling how the pandemic is likely to progress, it is essential for us to account for the time lag between onset of symptoms and the reported number of new cases that we see today. The effective reproduction number is the actual transmission rate of the virus at a given time point. It varies according to the measures in place to control the epidemic, such as the isolation of cases, quarantine of the potentially exposed, travel restrictions, school closures, and other physical distancing interventions. The measures implemented in several places like Wuhan and Switzerland seem to have been effective and reduced the effective reproduction number to less than 1. Although altogether, these interventions are curbing the spread of COVID-19, but they cannot last indefinitely as they come at high societal and economic cost. The questions now are, how do we know what to lift? How much can these interventions be relaxed? It is very difficult to actually discern precisely which measures are most effective. What we know is that when we lift the interventions, we will see more transmission events. So instead, we should keep the interventions that are less disruptive to our livelihoods, but more effective at mitigating the spread. In fact, some researchers also suggest that we may need to consider intermittent physical distancing for a period of several months, in fact years even. So have circuit breakers every now and then. Because a combination of several interventions in China were implemented, we have witnessed how the epicenter moved from Wuhan to other cities outside of China. Will the epicenters continue to shift? It very well may, and it depends on how well countries or cities curb the spread of the virus. There is no model answer to best respond to such a complex pandemic. The timely implementation of control measures is key to the success, and it must strike a balance between early enough application to reduce the peak of the epidemic and ensuring that it can be feasibly maintained for an appropriate period of time. Some optimistic forecasts suggest that a vaccine could also be ready in 12 to 18 months. However, researchers are already warning that it might not be physically possible to produce enough vaccines for everyone. And in fact, the more prosperous countries might hold the supplies. Moreover, the strain of COVID-19 pandemic puts on health system comes in different forms. Suspended vaccination programs for other diseases is an example of how there could be other long-term consequences. More than 20 countries have suspended measles vaccination campaigns in order to cope with the current COVID-19 pandemic. So we have seen very clearly that the rapid spread of this current coronavirus illustrates how infectious disease respect no boundaries, and that we need to work together to tackle this deadly global threat. Yeah. So I'm done with what I have to say about how mathematical models can be useful.
Thank you very much, Kiesha. And for those who have just joined, that was Dr. Kiesha Prem, a research fellow focusing on the modeling response, not just in Singapore, but also equally in the United Kingdom, as well as working on the modeling data coming out from the rest of the world. She's based at the London School of Hygiene and Tropical Medicine, as well as the Swee Hock School of Public Health. Kiesha, while you were speaking, several questions that come in that will be relevant to you, so you can perhaps think about it. One question that is very relevant is really around Wuhan took about 12 weeks before they could let up their quarantine measures, and whether, in your opinion, based on the data, is Singapore likely to also have to endure a 12-week window as well? So that's something for you to think about, while I invite Ms. Caitlin Asjes, the Senior Director over at Becton Dickinson, to speak a little bit about what is the economic impact and really how have countries responded to the pandemic. Over to you, Caitlin.
Thank you, and I'm very, very pleased to be on this panel this morning. Thank you for the clinical overview and the mathematical modeling overview. What I'm going to talk about is, I guess, externally, how are governments responding? How is that impacting us as companies? And then also talk a little bit about the question, is the cure worse than a disease? So I think to start with how governments are responding, we've seen pretty much in every country in this region and around the world, some flavor of lockdown. I think Korea is probably the notable example. Whether we call these lockdowns circuit breakers like we do here in Singapore, social distancing measures like we're seeing in Vietnam, or full-on quarantine like we're seeing in the Philippines and Luzon. All of these lockdowns are basically to safeguard populations, to flatten that curve so that we're able to not overwhelm the healthcare systems. And within those lockdowns, we're seeing governments that are trying to make sure they safeguard at least the essential businesses, the delivery of healthcare, the manufacturing sectors that are important for things like PPE or medical devices, and certain kind of key sectors in the economy. And I think this is, there's mixed success here. Of course, there's a need to balance keeping businesses and the economy open, but also the impact on public safety. I think an example of where we're seeing this is right now in Malaysia, where even essential businesses have been required to restrict their operations to a 50% headcount. As a manufacturer in Malaysia, we face the challenge of keeping up the production of our essential medical devices at that 50% headcount. But that's not just an industrial question, it's a public safety question as to why we have to stay at 50%. And so the economic impact of this is monumental. I don't think any of us have seen an economic impact like this for other areas. And I think it was very relevant what Kiesha said before about how our models are all simplifications of reality. So I think you have to take every economic estimate of economic impact with a grain of salt, realizing how that model has simplified the economic impact and where it's coming from. Just today, in the headlines, there was a piece of research that came out of Australia National University and King's College London, where they estimated that over 500 million people may fall into poverty as a result of COVID-19 and the lockdown restrictions. That's between 6 and 8% of the global economy that could be forced into poverty because of the impact of this lockdown. It can set our fight against poverty back by a decade, or again, this report said as much as 30 years in regions such as Sub-Saharan Africa, Middle East, and North Africa. So I think we're going to see a huge economic impact. Unfortunately, this is going to be disproportionately impacting the poor, both developing countries as well as the poor communities within developed countries. And so I think because of this large economic impact, there's been a lot of folks that have asked across the political spectrum have asked, is the cure worse than the disease? We've heard politicians, our friends, talking heads on TV all ask this question. I think early on in the epidemic, Bill Gates had one of the most stark rebuttals to this line of thinking. Is the cure worse than the disease? He said, well, there really is no middle ground. And it's very tough to say to people, hey, keep going to restaurants, go buy new houses, ignore that pile of bodies over in the corner. We want you to keep spending because maybe there's a politician who thinks GDP growth is all that counts. So that said, I think we all want to preserve, of course, human life. But as the pandemic progresses, it's becoming clear that we're eventually going to have to make difficult choices about when to open up the economy, knowing that some may die, but also that, especially with developing countries, where there's no government social safety net, many will also die because of the impact of prolonged unemployment and poverty. And so this is really a kind of a grim calculus that requires the input of clinicians, economists, ethicists. In health economics, we use a term called the quality adjusted life year, and use the cost per quality as a way to make decisions about funding healthcare. The cost per quality really helps us, to put it in a grim way, it helps us make decisions about putting a dollar value on life. And I think a similar concept is going to have to be employed when making decisions around balancing COVID and the economy. Because like it or not, every decision we make is a trade-off. And those trade-offs should be explicit rather than implicit. So I'll leave my economic comments at that.
Thank you very much, Caitlin. And that was Ms. Caitlin Asjes, the Senior Director for Becton and Dickinson, which is very much involved in looking at the international and regional health response, particularly focusing on economic and social impact. So we've been getting very good questions. And for Caitlin, really, I think the question is around what are the lessons that are coming out from China and from South Korea in terms of the economic recovery potential that may be able to guide countries, including Singapore, not just European and American, North America countries on the economic recovery route. But I will come back to you while you ponder a little bit on that, which is really around strategies that we are able to learn from China, from South Korea, particularly for South Korea, because they have never implemented, up to today, they did not need to implement a lockdown measure where some of their economic activities were frozen. Now, but I want to very quickly come back to some of the questions that were posed. And Shawn, there were specific questions that earlier on I touched on around strengthening immune systems with vitamin C, D, and zinc. But equally, there have been a number of questions coming in around the role of chloroquine and hydroxychloroquine, including their role as prophylaxis for healthcare workers and other frontline workers. Can I have your thoughts to these two questions? The first is really around strengthening immune system. Does that actually work? And if it does, what are your recommendations around that? The second is on the role of chloroquine and hydroxychloroquine, both on the treatment perspective and also as a prophylaxis. Over to you, Shawn.
Yeah, about the vitamins, I think there are people who are out there, especially the elderly, who might not have a balanced diet. I think if you have a nutritionally balanced diet and replete in vitamins, you will not be as high risk and in need of supplementation as those who have an unbalanced diet. And I think it depends on different societies that you live in. For example, even in the US, there are a lot of people who might have certain food diets where it does not bring them enough nutrients and micronutrients. So I think in multiple randomized control trials, I mean, there is data for zinc, there is data for vitamin C in general in decreasing the number of acute respiratory infections. And of course, the data here is with the common cold viruses, and they seem to decrease the susceptibility and number of episodes. And these micronutrients are important as cofactors in enzymes in fighting infection. So extrapolating from that, then it makes sense that against COVID-19 and respiratory infections in general, having a diet which is replete, and if there's a concern, especially in certain subpopulations where you think that mineral or vitamin supplementation would be helpful, yes, those people, especially those at higher risk, it might make sense to take vitamins. If your diet is replete, then the necessity of that is not as high as those who have replete in diet. Obviously, these data are now, I'm extrapolating data from what we know of common respiratory viruses. We do not have data specific to COVID-19, but I think it would be a reasonable thing to do and something that people can watch out for. With regards to chloroquine, just changing gears a bit, there was a question about prophylaxis and another question about treatment. Now, chloroquine has a related sister drug called hydroxychloroquine. I will just say that in our national guidance, which is available on the NCID website, and we have disseminated to our public and private hospitals here. In fact, different national bodies and institutions have issued interim guidelines, and we have tailored some of our guidance according to the evidence that we know so far. In vitro, that means in a petri dish, we know that chloroquine and hydroxychloroquine, along with some other antivirals, for example, a HIV drug called Kaletra, and another newer drug which was studied for Ebola, but did not perform as well against Ebola. It's called remdesivir. These have activity against SARS-CoV-2. Now, what happens in a petri dish and what happens in the human body can be quite different. And I think while there are a lot of questions and there are concerns, and I think even as physicians, we do feel an immense amount of pressure when we see very sick patients. A lot of us feel like we need to do something. But one of the first principles in medicine is to do no harm. And of course, we cannot sometimes wait for all possible randomized control trials and also good quality trials to come out, because the patients are in front of us. And based on what we know with our experience with SARS, 2003, MERS, and related coronavirus, SARS-CoV-2, and the available clinical experience, we do need to extrapolate some of that data. And in patients, with patients will be a nuanced discussion, and with their caregivers or their guardians, that drugs with antiviral activity and which are safe, where the possible benefits outweigh the risks, we would use that. So in our national guidance, we have carefully nuanced it that hydroxychloroquine might have some effect against the virus. We know that that is true in vitro. In human data, the trial data emanating out of China, out of France, and multiple other places have been contradictory at best. A lot of the trials, which sometimes get sensationalized in newspaper front pages, are often sometimes poor quality and not well designed. Now, this does not mean that we do not use these drugs. We are waiting for good trial data. For example, hydroxychloroquine has been used for a long time in our rheumatic patients with rheumatoid arthritis, and compared to its sister drug, chloroquine, it is safer and has 40% less toxic effects, for example, on the heart. Now, some people have used chloroquine, and there are even reports of a guy in the States where he bought chloroquine over the counter from a pet shop, and he took it and he died because of cardiac from poisoning. And some people have used chloroquine. It has an effect on lengthening some of the electrical intervals of the heart and leading to a condition we call arrhythmia. And that in itself can be life-threatening. So chloroquine has different toxicities on the eye and the heart. And we, in our national guidance, we advise against using chloroquine per se. But with a caveat that we can consider hydroxychloroquine in certain groups of patients, but with the knowledge that we are still awaiting good trial data. Now, amongst all the drugs, there are a number of them in our national guidance, and some of them are only available as part of a clinical trial. So one which is hotly studied now is remdesivir, and a paper in the New England Journal came out this week. We know that it is relatively safe and that it exerts quite potent amongst all the drugs that I've described so far, antiviral activity. So we are waiting right now for this drug's full trial data to come out, and also wider availability of this medication. There are other drugs, for example, Kaletra, that is found its way in our national guidance. There was a big trial of over 200 patients in China. Unfortunately, sometimes the trial design does not help us to answer the question fully, but they studied over 200 people, and most of these patients were the median onset of illness was about, at the time where they got randomized into this study, was about 13 days. And there was an exceptionally high mortality rate because of late enrollees. It was about 20% in this study. So in this study, Kaletra did not show the effects of mortality benefit or in the primary analysis decreasing the time to clinical recovery. In some sub-analysis, it did shorten time to clinical recovery in a modified intention to treat analysis, which means that the people who are assigned or randomized to get the drug that they're supposed to get actually got the doses, and that shortened illness by 15 days from 16 days. Now, 1 day difference, I'm not sure what to make of that as a clinician, but again, the trial was designed as such, and I mean, kudos to our Chinese colleagues who were able to even do such a nice study amidst very stressful circumstances. I think it has helped us answer some questions. All the numbers in that study showed a bit of benefit towards Kaletra, but again, statistically, where we set p-values at 0.05, and of course, there's a whole debate again, should we set significance at 0.05, and what does that mean? It's a bit more of a traditional thing, and there's a huge debate on that itself, but the numbers seem to be in the right direction. But if you poll my department and many infectious disease physicians, then based on the data that we have, you might get varying opinions. So we are not so sure whether, we are quite sure now that Kaletra will not work as well in late disease. That's what the Chinese trial demonstrated. But could it have an effect when we started early? And I think that is not so clear. Kaletra is definitely much more widely available. And but then if there's a more potent drug, for example, some of the other drugs I've described and other drugs which are repurposed or new drugs, then of course the standard of care would shift towards those drugs that are proven to be ultimately beneficial from both a mortality standpoint and also to prevent people from going into the ICU. So it's still an evolving field, and I think we have to constantly update our guidance as more data comes out.
Thanks, Shawn. So I think just to quickly summarize, on the issue around immune system, it doesn't hurt. Things like vitamin C, vitamin D, zinc, boosting your immune system, it doesn't hurt you to take on. But on the issue of chloroquine, hydroxychloroquine, whether as a therapeutics or as a prophylaxis, really, I think we need to wait for the world to generate more evidence. There are the WHO solidarity trials are looking at some of these issues very carefully, combining evidence from multiple countries before proper recommendations can be put forward. I think that. Over to you, Kiesha. I think there have been many questions really focusing around the issue of the spread and what can we learn about how long does it take for national measures such as those implemented in Singapore or even the movement control restrictions that have been implemented in our neighboring countries, in Malaysia, other parts of Asia. How long do we think it will take for these measures to be effective? Particularly given that Singapore now, we seem to have two fronts that we're fighting. One is on really domestic transmission, and the other front is affecting our foreign migrant workers as well. Over to you, Kiesha, for some comments on that.
So Wuhan took 12 weeks to let up the stringent social distancing measures that they had implemented. What would it look like in Singapore? And I'll try to sort of say, much has happened since late last year when the documented outbreak began in Wuhan, China. Today, more than 180 countries are affected by the coronavirus pandemic. So you're going to get infection pressures from many different other cities, and you don't know where are you going to import cases from right now. It's not just one source, it's at least 180 different sources. When Wuhan and the rest of China implemented the stringent measures, we saw that the effective reproduction number went below 1. On some days, China was not reporting any new cases locally, but many of the cases that they reported were actually imported. However, we also saw that when the interventions were relaxed, local transmission resumed, but perhaps at a much lower rate than it did before the lockdown. So it tells you that containment measures are still essential to contain the curve of future spread, and we cannot relax these some of the containment measures like isolation of cases, quarantine of the potentially exposed, and etc. For Singapore, it's actually difficult to evaluate if the 12-week lockdown would be firstly feasible and secondly sufficient. As Caitlin mentioned, that these measures have a big impact on the economy, and if there's no economy, there are no resources to sustain the health system. So in Singapore, we implemented the circuit breaker, and we need to evaluate the effectiveness of the circuit breaker measures. And I'm pretty sure that the School of Public Health in Singapore are doing it right now. However, the dynamics of as you mentioned earlier, that the dynamics within the general population is actually very different from the dynamics in the migrant population in Singapore. The migrant population in Singapore some of them live in dormitory settings, and we clearly see that the current measures to keep them quarantined in one location would actually cause a bigger spread between the infected individuals and the currently still susceptible individuals. So it's very important for us to separate infected individuals from the susceptible ones as much as possible. And we need to actually do our best to contain the spread in all subpopulations, whether resident or migrant, in order for us to contain the pandemic in Singapore. Some researchers have suggested that we should consider intermittent physical distancing measures, which may have a smaller impact on the economy and society in general. Perhaps more circuit breakers every now and then, and early enough for us to reduce the peak and catch it actually before it starts rising up again, could be something that we could consider.
So thanks very much, Kiesha. And this actually comes back to a point that were raised in several of the questions that have been posed, which is really this concept around flattening the curve, as well as versus letting nature take its course, striving towards the concept of herd immunity. And for this particular aspect, I would like both Caitlin and Kiesha to comment at some point. So Caitlin, this comes to you as well. Kiesha, when we start to talk about flattening the curve, there's always this perception that we are just trying to minimize the number of people that is coming into the health system. But equally, from the modeling perspective, I know that yourself, colleagues like yourself and Professor Alex Cook, they have also been looking at modeling not just the number of people affected, but equally the number of ICU beds, the number of ventilators that will be utilized at any one point. So not just the infected people, but also the availability of essential core resources in the healthcare system to address some of this, including medications that Shawn earlier on talked about. Kiesha, can I have your comment on this bit about why we really still need to focus on flattening the curve, or should we just let nature take its course, aim to adopt some of the strategies that Northern European countries have seemed to be embarking on, focusing on striving towards herd immunity? So that's a specific modeling question to Kiesha. But Caitlin, I wanted to have your thoughts on this around flattening the curve, having multiple circuit breakers or lockdowns in the interim, but this risk stretching out the economic winter for a substantial long period versus letting nature take its course. Maybe if we have COVID parties, very much like chickenpox party, the population may strive towards herd immunity within 6 to 9 months. There will be tremendous health consequence. Very many people may die from it, but economically, it seems to be a reasonable strategy. Caitlin, for you to comment on that. So Kiesha, you first on the modeling impact, flattening the curve versus let nature take its course. Kiesha, please.
So we say we let nature take its course and we try to, and they try to strive for herd immunity, but do we actually really know how long does immunity last in the recently recovered? So there are evidence to say that, people could be reinfected, and I still feel that we are at a stage where we still do not know enough about the current pandemic that we're facing for us to say that herd immunity is a solution. I think it's too risky to say something like that. Therefore, it makes it more important for us to think of measures that can flatten the curve. Because if you flatten the curve, you're able to make sure that the health system does not fully collapse. You give the health system a chance to respond to the new infections that stream in every now and then. And that, we clearly see that for many individuals who are relatively young and healthy, they can survive. And when they survive, we hope that they have some form of immunity and some form of protection for a period of time. So if we are able to look at solutions and interventions that are able to, help us keep the number of new infections every day at a low level such that the health system can cope with it, then perhaps we would be able to contain this pandemic even better. And this takes into account the fact that we have to also model the number of ICU beds, the number of ventilators, the number of hospital healthcare workers, and the resources that are needed to keep the health system functioning. So I think that's really important.
So thank you, Kiesha. You mentioned the word immunity and antibodies. So Shawn, later on, I'll come back to you really to discuss some of the concepts that have now been circulating in different parts of the world around this idea of serology passports or certificates, immunity passports. We will ask you to explain a little bit about what the concept really is about and whether it is likely to work in the long term. But I wanted to have an economic view of the response around flattening the curve, but prolonging the economic winter versus letting nature take its course, let 6 to 9 months have a very devastating health impact, but at least the economy may be able to recover quickly, bearing in mind that the trade-off here is that if we have a prolonged economic winter, what we are looking at is a very real case of a humanitarian crisis where many people may suffer tremendously because they are unable to adopt lockdown measures that the wealthy nations have been able to execute. Caitlin, what are your views on that?
It's not an easy question. But one thing I just wanted to comment on first, building on Kiesha's point, is also the idea of the flattening the curve and our lockdowns to do that is not just about the ICU, but it's about biding us more time to get ourselves prepared. It's about time, really. When we lift lockdowns and when we go back to work, the virus is going to be there, no matter how long we wait, right? It's still going to be there. But what the lockdowns do is, in flattening the curve, it also gives us more time to be prepared as a society and a health system. So we know from experiences in China and Korea that what works is testing as many people as possible, doing solid contact tracing, and then eventually also having the technology such as serology tests to get people back to work and measure immunity, having that infrastructure in place. So I think there is a reasonable case to say we should continue these lockdowns to give us the time to get ready to be able to maybe open up our societies slowly but carefully, making sure that as we open up, we're maybe doing it, starting just the most impactful activities first. Probably concerts don't need to happen for a long time, but schools should open, right? So I think we're going to have to look at this in a very balanced way. And I think too, each country is going to need to look at it in an individual way, because again, the economies are so different. And so I think the question is not, no lockdown or, basically herd immunity and let people die versus total lockdown for a long time. I think we're going to have to eventually find a balance while making sure that we can do the best for the economy, but also do the best in terms of society and our morals, right? We can't just let people die without really building the right infrastructure.
And Caitlin, since I have you on, there have been a question around really what is the impact on the low resource countries, such as the low and middle income countries, on this lockdown measures. In particular, you highlighted the use of a quality approach, but isn't that somewhat dangerous? Because when we start to adopt a quality approach, it seems like the mathematics always tend to favor the richer countries. Over to you, Caitlin, for some comments on that.
Very good question. And I'm not sure I don't think maybe the quality is the right approach, but I think it inspires the idea that we have to start to think about how do we put some numbers on these decisions that we're making, whether it be quality or whether it be disability adjusted life years, which is another measure that's actually meant more for favoring the developing world. Again, I think there's a lot of research we still need to do, but the key point is that we can't just say, okay, we're going to save life at all costs from the virus while not paying attention to other areas of the economy or even other areas of healthcare, such as chronic diseases, patients that are foregoing elective surgeries that may become required surgeries. So I think there's a lot of really tough trade-offs we need to make, but we can't be shy from putting numbers around them. And I think, especially in the developing world, we have to really look at how those economies are structured, and really whether the right social safety nets are in place. So if you don't have the right distribution of food, we talked earlier about immunity. If you have a lot of children that are affected by severe acute malnutrition, our ideas that young people won't be affected by the disease are based on healthy young people. If we have young people who are immunosuppressed because of severe acute malnutrition, that might change some of the disease dynamics. So it's the toughest challenge of our time, I think. But we have to go into eyes wide open and really bringing in multidisciplinary teams to make those decisions.
Thank you, Caitlin. So you talk about trade-offs. And I think this is where I would like to come back to Shawn, because Shawn, earlier on, I talked about this concept of serology certificates, which is seen to be a trade-off, allowing people to be tested this time around, not for the active virus, but for the presence of antibodies. So the first question is, could you perhaps explain a little bit about the two types of tests out there? One is the antigen PCR test, and then one is the antibody serology test. So at least our audience can have the background before we move on to the next question around the use of such a strategy on serology for deciding how communities or countries can get back on their feet by allowing people to resume activity. So first question, Shawn, on what is the difference between the two types of tests out there? Over to you, Shawn.
Yeah, so the primary way we diagnose COVID-19 is through a molecular test called PCR, and that stands for polymerase chain reaction. It's a molecular test, kind of like at a crime scene, you look for the genes of the offending, the criminal. So then the criminal in this case is SARS-CoV-2. So we are looking for the genes of this virus, and we do it through this molecular test. Now, it looks for genes, so it does not necessarily mean that the virus is alive or viable, but we know that the virus RNA is there. As opposed to antigen tests, now we are not really using antigen tests, and I'm just drawing that distinction here. Antigens refer to proteins, and for example, in the market for influenza, a lot of GPs use rapid antigen tests. Those look for viral proteins which are shed from respiratory secretions. Right now, the HSA in Singapore has licensed 2 rapid tests, but they are antibody tests. So antibodies are substances which are produced by the body when you're exposed to the virus to fight the virus. So those are antibody tests. The antibodies directly, they bind antigens which are produced by the virus. So locally, we do not have any licensed antigen tests, and I don't think there's a lot of good data out there, although some antigen tests are in the market in China and elsewhere. Now, to have a good antigen test that can be deployed in a GP setting would be great. I just would like to caveat that our experience with other antigen tests, for example, influenza, in the older days when antigen tests for influenza first came out, this was even during the flu pandemic in 2009. They are like a bit like your pregnancy test strips, and you look and you sample a respiratory sample and you see a line turning black and you say that, okay, it's positive. Those early in 2009, those flu antigen tests, the sensitivity was only 50%. So actually, although people are marketing and have rushed to the market with some of these tests, we really do need to see the performance characteristics. Now, the sensitivity of 50% means that if 100 people with the disease, you can only diagnose 50 people, which is almost like flipping a coin. I could literally take out a 50-cent coin and flip it. If the sensitivity of the test is 40%, you flipping the coin, you can diagnose better than a lousy antigen test. So you need to be quite careful with that. Now, with the antibody test, that demonstrates immunity. And unfortunately, we did look at one of the antigen tests in our investigations at NCID. The antibody test was good, but it only turns positive after about 14 days after the onset of illness to develop early antibody response. And there are 2 antibodies we look at, they're IgM and IgG. So, the early, such a test where we can detect antibodies, but only after 14 days, it is not of great use in the early period. If it can only detect at 14 days or after. Of course, if you have an antibody test which can detect at day 7, for example, like we do for dengue, we have some good kits out there, then that will become much more useful. But if it is delayed, then antibody tests are not that helpful. So the mainstay is still this molecular test, which is a fairly complex test and needs to be done in the lab, but is highly accurate. And it's what we consider the gold standard for diagnosis right now. Then you have antibody tests, which are those that we do on the rapid tests on paper-based assays, may not be as accurate as those performed in the lab. And sometimes we do it on plates or in the lab, and those are kind of more, or we actually, it's done in higher biosecurity level labs where we do what we call a viral neutralization test. And that needs to be done in a biosafety level 3 lab. Of course, there are other serologic tests which are in the market now and which you do not need to do in that high biosafety level. If the serum from recovered patients, it's safe, and then if, or you do an inactivation step. So these serologic tests look for immunity, and this begs the question, and they are actually more accurate probably than the paper-based test or a more recognized gold standard for serology. But no one knows the problem with immunity passports. How long does immunity last for? Now, if we draw lessons from SARS and MERS, for SARS, we have some data that immunity can last for about 2 to 3 years. In MERS, limited data, a number of them, when they have studied both from the Middle East and Korea in small subsets of patients, like about 10 patients or so, they have found that about 80% might have immunity up to 18 months, but this means 20% don't. And the immunity seems to be correlated with the severity of illness. So you have a severe pneumonia, then you have a more long-lasting immune response. If we have mild disease, some people actually revert to have no antibodies detected. Now, if they were theoretically re-exposed to COVID-19, the question is, will they get infected again, or will the body mount an immune response and prevent a second COVID infection? Now, this is a question nobody has an answer to, whether you can get infected a second time later on in the disease. Now, we don't think that in acute illness or shortly after the illness, people get reinfected straight away, because most of the time we would, from what we know of other respiratory viruses and coronaviruses, you will mount an immune response and you don't get infected straight away or double infection or just relapse suddenly. Although some people have brought that into question. For example, some of the Korean data, they're looking at early reinfections. We think that maybe because when we detect DNA, our tests, for example, when we take from the nose, it may not be, it sometimes is detected intermittently just because of how good the sample is taken. And, or sometimes at low levels where the level of virus, nucleic acid or genetic material is near the limit of detection of the PCR assay, it might flip from negative to positive. But again, detecting the DNA doesn't mean that it is a viable virus and you necessarily will infect other people. So we don't think, at least scientifically, that this people, at this point, we don't have strong data or data that people get reinfected straight away after they get COVID. I don't think medically or biologically that is likely. There's some data where they tried to reinfect monkeys in China, and I don't think they showed that the monkey.
Shawn, we seem to have lost you. Could you check your mic?
Oops, let's try to get Shawn back.
Right, we may have lost Shawn. But
oh dear.
Anyway, so I think while, okay, so what I'll do is I'll very quickly summarize some of the points that Shawn made, because those were very important points that Shawn has made. Because the first point that he made was really around that PCR test is used to test for the presence or absence of the virus in someone who is actively being infected at the moment. Whereas the serology antibody test is really to try and find out, has someone been exposed, has been infected in the past? And it seems that from what Shawn has mentioned, it takes about 14 days at the very least for the antibodies to show up. So it is something to test for whether someone has been exposed before. And some of the strategies that are being proposed right now in parts of Europe, even in America, has really been around this concept of immunity passports, which is really looking out for the presence or absence of antibodies in individuals, and individuals who carry the antibodies are automatically assumed to be immune to reinfection. Shawn explained also that even with the data that is coming out from Korea, from China, that the risk of reinfection within a very short period seems to be much lower, but clearly more science and more research has to be gone into this area for us to have a very conclusive view on that. But at the moment, the view is that there is a degree of protecting antibodies for someone who has been infected with COVID-19. But there are two very important unknowns at this point. One is, how long does that antibody last in the body to protect against further reinfection? Is it a case of 2 to 3 years, like what Shawn has mentioned for SARS, or is it even shorter? Even if it's 2 to 3 years like SARS, that alone is worrying, because it does mean that assuming the validity of an immunity passport or a serology certificate may not be the right response for a global response to take in trying to identify people who have been infected before. Now, I noticed that we are we have reached the hour, and I wanted to very quickly get Kiesha and Caitlin to give some final concluding thoughts. Really, Kiesha, one thought from you, quick thoughts on really how should countries unlock? Can the mathematical models really provide some guidance, particularly real-time guidance on whether some of the measures as we unlock are likely to be important or not important? Because I know that one of your landmark publication has really been around how should China be unlocking subsequently. And then Caitlin, very quickly also, in your opinion, will the economy only recover when countries are able to completely eliminate COVID-19, whether it is through the presence of a vaccine or whether through a sustained period, perhaps for 2 weeks, where there is no infection anymore in the whole world? So Kiesha, starting with you first. How should countries unlock? Can mathematical models be used real time to guide? Over to you, Kiesha.
So I think mathematical models can guide interventions real time, but these models require really good data to provide useful inputs for informing policies. And in fact, how do we recommend that countries unlock? Firstly, you don't go from completely locked down to completely 100% reintroducing everybody into the population. In fact, what we recommend is that to introduce the population in a phase-like manner. So you allow for like maybe perhaps 25% of the workforce to resume, and then the remaining additional workforce or split business teams to start returning back to the workforce. So firstly, do not suddenly reintroduce everybody at the same time, but do it in a way such that if by reintroducing a certain part of the population, you realize that your numbers are climbing and your effective reproduction numbers going above 1, then you can go back to actually trying to do a circuit breaker again. So it wouldn't be to just move from complete lockdown or like a circuit breaker to full reintroduction, but to do it in a phase-like manner such that you can evaluate if the reintroduction is actually helping to sort of get the people back into the population and mixing again. And I think it's also important to study how people's behavior change during this whole outbreak period. And some of the researchers in some European countries and even in Singapore are evaluating how do people change their behavior during a lockdown period, during the outbreak period, and during different other measures in the future. So we evaluate how people change the way they come into contact with other people every 2 weeks during the progression of the pandemic. So I think that's critical to know, and it helps us with the modeling because it helps us as it provides inputs into the models. Yeah.
Thank you very much, Kiesha. I believe your last point really was on modeling human behavior because it directly affects the reproductive number if human interactions decrease tremendously during this period, even because of social behavior or social aspects or just because of regulatory measures that have been put in. Caitlin, very quickly to you. What we've heard from Kiesha is somewhat worrying because it seems to suggest that even when the unlocking does happen, it will be a while before we can resume the full level economic freedom that we had enjoyed in the early parts of January before COVID hit the world. What are your thoughts to this? Is it true that the economy will only recover when countries are able to completely eliminate COVID-19, where we are no longer talking about a mitigation strategy, but a complete elimination? Over to you, Caitlin.
I don't think we can wait for mitigation and to starting to recover our economy. I think the world's going to be different. There's going to be a before and an after, and there's never going to be a going back. So I think the economy is going to have to recover in new ways. We'll probably see the economy recovering sector by sector as economies are opened up. So in my previous example, I think we'll probably see school and travel open up before we see large concerts. But I think we'll also have to look at maybe new ways of doing business. So I think we have seen encouraging signs of more businesses going online, of fashion labels thinking about sustainability. of just-in-time production models. I think we're going to see a lot of creativity that's going to help us get back to business sooner. But yeah, I don't think we're going to see full economic recovery for quite some time. Sorry to end on a negative note.
That's a very sombering note to end off. But with that, thank you very much to the panelists, as well as to the audience for staying with us for the hour. We have Dr. Shawn Vasoo, Clinical Director at NCID, Dr. Kiesha Prem, Research Fellow at London School of Hygiene Tropical Medicine and the Swee Hock School of Public Health at NUS, and then Ms. Caitlin Asjes, the Senior Director at Becton and Dickinson. Thank you very much for joining us for this hour. We hope that this has provided a useful introduction and guide really into the coronavirus world that we are now living in and how governments are responding and the likely impact to life and livelihoods. With that, thank you again. Sian, shall we just end off here or over back to you, Sian?
No, this is great. Thank you for joining, everyone. We'll see you at webinar number 2, which will be next Monday, 20th of April. Bye, everyone. Stay safe.
Bye.
Thank you.
Thank
Bye.
you.
Thank you very much again.